So good morning, everybody. Thank you so much for joining us very early here in Geneva. I know there's many activities happening. My name is Dr. Camilla Sasson. I'm with the American Heart Association, and on behalf of the AHA, as well as all of our partners here, we appreciate you coming in this morning. We're going to have a very action-packed agenda, as you will see in just a few minutes as well. But just welcome to Geneva, welcome to ACAN. The first question I had was, what is ACAN? So you will learn much more while you're here, but it is the Acute Care Action Network, and it was actually launched here in 2023 as a result of the ECHO resolution, and really as a response to say why it's so important to integrate emergency critical care and operative care. So today's theme will be a lot about integration, breaking down silos, and really thinking about how we can move into the future, thinking about economies of scale and how resources may be limited, but we have an opportunity to really become more efficient and hopefully have a better experience from the pre-hospital setting all the way through to the to hospital discharge for our patients. So with that, I'm going to go ahead and introduce our next esteemed speaker, Professor Moldovan.
Thank you very much. Good morning. It's a great pleasure and an honor to be here with you. So I will let you know in a few words about our national system of emergency and critical care. Currently, I'm not anymore Secretary of State in the Ministry of Health. For 2 weeks, I am the President of National Health Insurance House. So I switched from the pure medicine to insurance, but on my previous job at the Ministry of Health, I coordinated the Department of Medical Emergency of the Ministry of Health in Romania. And I will let you know how we structured our national system in this field. So there are two important actors. The first one is, of course, the Ministry of Health. And the second one is the Ministry of Interior Affairs. So there is very close collaboration. And everything started since many times, more than 100 years ago, but like 25 years ago, in Romania, something happened. So we had a very valuable colleague. Maybe some of you, I'm sure that some of you know him. He is Dr. Raed Arafat. He came to Romania from Jordania in Târgu Mureș, which is in fact my town, and I had the pleasure as a student at the Faculty of Medicine in Târgu Mureș in Transylvania, in the middle of Romania, to meet him and to work with him at the very basis of this new emergency system in Romania. So everything started with a small emergency room here in Târgu Mureș, in my town, with 2 beds for critical care patients, 5 beds for the so-called yellow code, and 5 beds for so-called green code. And there were a lot of problems because this was something very different. We started in a different way. So for the first time in Romania, the doctor left the hospital with the ambulance and went to the emergency cases, which was something very new. Since then, this system multiplied at the national level. So now there is very clear attributions for our former and still active emergency department or the so-called ambulance. So this system is managed by emergency doctors and emergency nurses. And this system, complementary system for critical care patients, which is managed together with the fire department at the local level. So at the fire department at the local level, they used to deal only with the fire, not with the health premises. Since then, this system created the so-called paramedics in Romania. This is something new, and they are trained in 2 actions, in 2 directions, for the fire and also for providing the first aid, the first response. So they are nowadays the first responders. Regarding the finance system of this emergency system here in Romania. So there are three sources. One is the state budget. One is the state budget via the Ministry of Health, and we finance in this way all that means emergency rooms, expenditure, and the so-called former ambulance system I discussed about. And also there is the budget of the Ministry of Internal Affairs that finance the part of the fire department expenditure. A part of this emergency core system, we have this in Romania, the so-called national priority actions. These actions are a kind of health programs dedicated to critical patients after the initial phase. What does it mean? For example, a patient with acute coronary syndrome, of course, or a patient with other critical diseases. There are 12 important critical diseases that we finance via these priority actions. So there are a lot of money spent in critical patients. So we realized that our national system is based on DRG is not enough for financing these critical patients. So we came with these priority actions, and we finance material, medication, and some equipment in order to fulfill the financial requirements. So basically, this is our national health system. I don't know if this fits very well in your within your strategy, but it's something new. It's something from the last 25 years, and we are happy to share information with you and to improve our national system for the critical patient. Thank you very much. If you have any questions.
Thank you so much. I know that you have to get over to the parlay. So if there's any questions for Professor Moldovan, we can take one question. Yes.
Just congratulations.
So,
I'm sorry.
So fantastic outcome for your country. Fantastic. Yeah, no, I just want to say that.
thank you so much. It was a real challenge. So I was prepared with my wife. With my wife. She goes to the doctor, but we were just to hear the results in a different. Thank you very much.
And I think you just really illustrated the importance of thinking about emergency care from the start all the way through to the finish. And I think the example that you've given us for Romania actually gives us a lot to think about in terms of how to revolutionize an emergency care system. So thank you so much again for joining us. We appreciate it.
Thank you very much. Have a nice day. Thank you.
Next, I'd like to introduce Dr. Terry Reynolds from the World Health Organization.
Thank you very much, Camilla. So listen, I mostly want to spend my time standing out of that spotlight, welcoming you guys. So we are here today, friends and colleagues here and online, to come together as ACAN. My name is Terry, and I head the ACAN Secretariat for WHO, and this is a WHO hosted network, but it is really happening because of all of the incredible colleagues you see here who have organized this side event and who are driving really the activities of the network. And we have about 67 organizations formally in the pipeline right now, and another 20 or so along the road to getting our applications completed. So I like to think that everybody in this room in some way or another is either part of an ACAN participant organization somewhere in the pipeline, or you are the future of ACAN. So one or the other of these things. And I hope that each of you identifies with it in that way. I also want to invite you, welcome you rather, to Geneva. It has been quite a rocky year, as you know, and this is quite a special World Health Assembly. But the fact of assembly itself, we should take a minute to recognize how incredible that is. This is the first morning of the first day, and assembly itself is an astonishing phenomenon. It's countries who, some of whom are allies, some of whom are strangers, some of whom are actually at war. And all of them are bringing their flags together this week for health. So I think it is powerful and helpful every day of this week to remember what's happening and why we're here. Similarly, we have come together as organizations and we're making not only a kind of philosophical commitment, but a technical commitment. And that is what the Acute Care Action Network is. We're making a technical commitment to taking action together. What I mean by that is this is not a coalition of convenience because our individual visions and missions happen to overlap. It is something much stronger than that. It is a commitment to take that overlap and step outside of it and go beyond it to a common vision. And there has been compromise along the way. There has been collaboration. There has been coordination. It is a very different thing. And I want to say we, friends, colleagues, and you almost want to say in this environment, comrades in arms, but these metaphors are very important. And this is not so much a battle as a quest. There is not going to be a moment when we have definitively won something, but there are extraordinary milestones along the way. And you simply don't go back from having empowered a community or a country to save lives. So we are on a quest, there are these milestones, and we are on this together now with a common and unified vision. And you will hear more and more about that in terms of ACAN and how it works. And for those of you who are able, we welcome you tomorrow evening at the side event, where we'll be announcing some very important information kind of about how we're going forward, and letting you hear really from the ministries and the countries. So I can't thank you enough for being here. I know every single one of you has other places that you could be instead of being here with us. And I just want to welcome you to Geneva, to the Assembly, to ACAN, and even more so to the sort of transcendence of what we can do together that we could never do alone. So thank you for being here.
All right, I'm going to go ahead and invite our esteemed panelists to come up and join me here. If you'd like to, go ahead. Yes. Lem as well. All right. All right, so first we are going to be starting with Dr. Lem, who is a professor of surgery and secretary of the Ministry of Health for Cambodia. And just to give everyone a little bit of the background too, we'll be doing our panelists will speak for about 10 minutes or so. And then at the very end, we will do a Q&A. So if you can hold your questions until the end, that'd be fantastic. Thank you.
Oh, good morning.
Good morning.
Excellency, Chair, and distinguished guests, ladies and gentlemen. First, I'm very impressive to participate this important event. This new platform of the how we can integrate the healthcare system or the what we call the comprehensive care. I'm very happy, and I would like to share some. First is our gap as one of the low and middle income countries in the world. It has a lot of gap in first in for the human resource, the lack of the human resource, certain anesthesiologists or nurses in surgical care, and limited pre-hospital care infrastructure, including ambulance availability and trained staff of provider. And third, lack of the interdisciplinary collaboration and coordination, data collection and information literacy system is also still not at the level. but secondly, in the last few years, we received strong support from our government of Cambodia. So the health and well-being of the people has become the top priority of the country. So recently, the government has distributed the UHC roadmap 2035 and have a mandatory goal of 80% of the essential healthcare needed and provided. 80% of the sorry, 80% of the health cover of the expenditure will covered by the government and reduce the out of pocket. And parallelly, the government expand also the what we call the social health security fund, allow more people or population can access healthcare services. And the Ministry of Health in the new mandate of the government, the Ministry of Health have delivered the key strategy action to reform the healthcare system in Cambodia. We count from the promotion, the health promotion to combating the emergency, combating the infectious disease, emerging disease, and the disease from climate change, NCD disease, and also improving the healthcare quality at all levels of the health facility. Health Social Security Fund also counted, and health regulation is very important in the mostly in the private sector. So thirdly, the royal government support recently our government has support extra support to the emergency and operative care. The government delivered the budget for renew and reform the district hospital for the operating center and the emergency room, and also the referral system like ambulance or transfer patient or something like that. And the Ministry of Health also created the National Committee for Surgery, Obstetrics and Anesthesia. We follow the platform of the WHO, what we call UNSOAP, and then we just create a committee. But firstly, we create the teamwork or in every hospital from the national level to the district hospital. The own committee of the hospital, and not only include the surgeon, anesthesiologists, and nurses, but we also include the like emergency doctor or nurses and other specialists that are concerned to make firstly the diagnosis for the patient and the management effectively. Yeah. And by UNSOAP. And then we now we are in the phase of collecting baseline data from every hospital, and we will have data to analyze and to complete our national statistics plan called UNSOAP. And Ministry of Health also finalizing the National Health Workforce Development Plan. As I mentioned, we lack a lot of the human resource of the healthcare provider. So now we are finalizing this National Health Workforce Development to address the critical shortage of the health personnel, particularly in the rural and underserved area. And in the meantime, we are creating the a partnership or alliance between the national hospital with the provincial hospital, because in Cambodia, most of the national hospital, we have more facility, the specialist human resource and equipment technology. So, at the level of provincial and district hospital, we are shortage of the specialists and also equipment. So we create the alliance to allow the national hospital to help to help district hospital to come up with the technical level to take care of the patient. So in conclusion, Cambodia is welcoming and strongly support the ACAN platform to achieve the goal of integration ECO continuum care to realize the UHCs. Thank you for your time.
Thank you, Dr. Len. Professor Moldovan, I know that Professor Moldovan, I know that you do need to run, so we'll go ahead and definitely thank you again for joining us today. We appreciate it. And Dr. Len, thank you so much for talking about the policy implications and how that really goes into the idea of building from silos into seamless continuum of care in Cambodia. And we'll have an opportunity to discuss a little bit more about the policy side as well. Our next speaker will speak to us about the importance of clinical providers. Dr. Karima Khalid is an anesthesiologist from Tanzania who's going to be speaking on this.
Good afternoon.
Good morning, everyone. Thank you so much for the opportunity to speak to you on the clinical perspective of ACAN and what it can do for us. I'm so happy to be here today with all of you and seeing familiar faces that have taken me through my journey to being the person that I am to talking to you today. I see Terry here. She was one of my lecturers when I was starting to do my specialization in anesthesia. She was working in the emergency department of Tanzania. Tim Baker has been here with me since my residence, before my residency to this time that I'm working on this in this work. My WFSA colleagues have really worked hard together so much. Later, everyone here, so it's so good to see everyone together speaking the same language. And my journey as an anesthesiologist in Tanzania started around 15 years ago when I was working in theater in orthopedics and trauma, and a child died on the table. And I thought that anesthesia care is not as good as it should be in my country. And I decided to join anesthesia, although as I was doing my medical training, I thought I wanted to become a pediatrician, but I thought it was difficult for me because I love kids a lot. So, and I don't like seeing sick kids, so I can't work with them, yeah. So I started, when I did this work, I realized that at that moment, we were around 11 anesthesiologists in my country, and now the number has grown to almost 100 anesthesiologists in the country. I saw emergency department also grow quite a bit from that, a lot actually, and becoming strong from that time I was a resident to the time we're talking right now. And a lot has been happening in that area, also in maternal and neonatal care. But what I was seeing that we are really improving in providing this care in our theaters, in our emergency departments, in our ICUs. But then what happens with, I was receiving patients pre-operative, pre-emergency or pre-theater that were not optimized as well when they were coming to me from the primary health, because I work in the tertiary facility. So seeing patients coming in and they're not being optimized from where they were in the primary healthcare and towards their journey or through their journey to my facility. And they were not And it's only the very big things that were lacking in their care. This patient, for example, was seeing a trauma patient who was a traumatic brain injury, who just needed to have this secondary damage prevented by being given optimization in the blood pressure, in the respiratory system, being given oxygen, and this was not happening. And at the same time, we would work so hard in our emergency, in our ICUs, and in our theaters to provide very good care to our patients. We'll stay there for long hours and make sure that, okay, my patient is now breathing, I'll be in ICU, make sure that my patient is actually seated and just needing oxygen, and then refer them back to the ward where I believe they should be getting oxygen in those wards. But then it's very hard for us in my working place to be able to, provide care in theater and also go and check on your patients post-operatively. But I was very keen to see how my patients were doing, because most of the time we'll have these fights with the surgeons, like, oh, the patient is not optimal, let's wait and all that. So I was really keen to go follow my patients post-op. And what I was seeing is that there are patients that we had really worked hard on, and then we lose them in the ward. Or sometimes we are called in to see these patients in the wards when they arrive. What I say to them, they will tell you the patient has changed condition, and please come in and help see this patient. So when you go in, it's usually very late. And the things that they were lacking, they were not recognizing these patients as they were getting worse and worse in the wards. And we really worked hard on them in the perioperative period. But then people are very busy, and there's a lot of non-patient based care that our nurses or our young doctors in the wards need to take care of, and they kind of miss to diagnose these patients early and provide them with the care that they need very early. So what we see is that our work becomes not futile, but it can be more optimal if we make sure that this continuum of care is being provided. And we had a very large study that was done recently in Africa. I don't know if most of you have seen it, the African Critical Illness Outcome Study that was conducted across 22 countries in Africa, 180 hospitals. And we saw more than 20,000 patients participated in this study. And what we saw in this study was that these patients, I'm talking about, who become very sick, 1 out of 8 patients now was actually critically ill. And this critical illness is mostly maybe because we did surgery on them, we saw them in emergency, and then we did well, and then we took them to the wards or post ICU. So there's a lot of them in the wards that are critically ill. And we saw that more than 2/3 of these patients who are critically ill actually found in wards and not in our ICUs. We don't have the capacity for ICUs anyway, but mostly they don't need this advanced care. They need very basic foundational care to be able to survive in their facilities. So what we see, at the same time, we see that why were they dying? Mostly it's because they were lacking this very basic care. So they needed oxygen, but it was not provided. They needed to be positioned in a very good position. They were not, that was not done. They needed their blood pressure optimized, and that was not happening. So what needs to be done, as we together here with all our initiatives in all parts of what we do, we've seen this care evolving from being included as surgery, being included as emergency and ICU and anesthesia. Now we have the ACAN resolution that we are working on as technical people to make it actually be useful, impactful. So as ACAN, what I see us together doing is ensuring that this very basic foundational care, or all our vertical systems, or whatever we are doing in our areas of work, is unified by ensuring that our patients are receiving this very foundational care. I do a lot of training. I train people in my safe courses, fast courses. I do emergency courses to all the providers that I come across to do capacity building. It's one area that I really love working on. But what I see is that when I've sent people back, after we've trained them, they go back to environments that are not optimized. So they're not getting supported by the leaders. They're not supported by having these things. The environment is not well provided, the equipment, the consumables, very basic things, and actually lacking in their facilities. So I think as ACAN, we need to have come with the approach of working with the governments, as just our colleague have talked about here, as technical people sitting together with the governments and all the stakeholders in different areas, surgery, pediatric, maternal care, anesthesia, emergency, all across all these systems, sit together and ensure that the great work that you are doing. I just came from our Society of Anesthesiologists meeting in Tanzania, and there was so much work that has been done in pediatrics. We have a lot of specialists trained by WFSA now who are actually providing good pediatric anesthesia, good regional anesthesia, but then what happens to these patients afterwards is what we need now to make sure is really our unifying voice as ACAN, in the work they're doing. The dream is that we have is that no patient dies out of lack of the essential care that they need, which in this ACO's paper, the term is essential medicine critical care, but it's actually the foundational care that all patients need to have so that they survive that critical illness, and then the specialized care is provided to them, and yeah, all our work becomes more impactful. We're doing great work already, but we want to make it more impactful, more meaningful to the patients that we're taking care of. Thank you very much.
Thank you, Dr. Khalid. I think you really highlighted the most important parts of ACAN, which are really to think about how do we make sure from the community all the way through to the critical care, our patients are getting the best care. Oftentimes it's foundational, as you had mentioned. How do we make sure that we've got education and workforce development happening at the local level all the way through to the critical care level? And then, of course, also thinking about quality improvement and strengthening our health system. So if you think about the pillars of ACAN, you've actually mentioned all of them. So thank you. And integral to this, I would say, is our next speaker, Dame Okafor, who is our Director in Government of Chief Nursing Officer. As you can see, nurses are I would say, the foundation of all of the care that we provide. So we appreciate you being.
Good morning, everyone.
Good morning.
And special appreciation to my Chief Nursing Officer for being here. I know she has other, okay, thank you, meetings, but she had to prioritize this. I'm grateful, thank you. And thank you, ACAN, for inviting me to speak on this very essential topic from the Nigerian experience. So my name is Francisca Okafor, Director Nursing in the Federal Ministry of Health. Okay, so Nigeria, like you know, is a very big country of over 232 million persons with we have 37 states. One of the states can be called a nation because of the large numbers. And in Nigeria, we operate concurrent health management with the Federal Ministry of Health, where I work, having over 80 federal health, tertiary health institutions, the states, which is like the province, having each of them having numbers of general hospitals and their own peculiar health system management, and then the lower level, that is the local government. But these three levels come together with the health minister sharing in the National Council on Health, so that the country can actually harmonize on the directions to go with respect to health sector. So in Nigeria, emergency, critical, and operative care are often function in silos due to resource limitations, fragmented systems, and workforce shortages. Challenges we have include emergency care struggling with crowded and lack of adequate triage system. Critical care is under-resourced. We have few ICU beds, limited ventilators, but that had got better with COVID, funding us to getting these very critical health infrastructures. So we have new challenge, which is power, because most of these very critical equipment run on energy, and power supply in most of our federal tertiary health institutions has become a very huge challenge. We also have critical care being delayed due to poor referrals, theater backlogs, and inadequate bed spaces. As nurses, we know what we do, that we bridge these gaps daily, but it's always a constant struggle. And this struggle has suddenly become very real with us with the current migration of the health workforce, with nurses being mostly affected. So the experiences of nursing across the silos. In emergency care, nurses are usually the first contact, but with gaps in protocols, cases often fall through the gaps. And these gaps in protocols or policies we are mentioning, it's not that we don't have those protocols, it's not that we don't have those policies, but the issue is seeing it through to implementation. Critical care, when a patient deteriorates post-surgery, ICU beds are scarce. Nurses improvise with limited monitoring tools, power outages. Sometimes it's a case of family not being able to pay so that these services can be commenced. Because in Nigeria, people still pay heavily out of pocket. Delay between emergency room, operating room means that nurses manage complications like infection while waiting for the theater time. What are the strategies to break down these silos? Strategies of task shifting and training. Nurses are trained in basic trauma and life support and post-operative care to reduce these delays. In Nigeria, the National Emergency Medical Service and Ambulance System is still very much in its infancy due to delay in implementation and really stating how it should run. Integrated protocols like implementing a surgical emergency checklist, linking emergency room to operating room is actually what will help, with lots of trainings to the healthcare providers. And by that, I mean integrated training. Community engagement. As nurses, we're educating families on early warning signs to reduce late presentation, and also educating them, actually advocating and sensitizing them to get involved with community health insurance schemes. Because emergencies happen, accidents and trauma do occur, but they don't give warning as to when they will happen. So since mostly you have to pay out of pocket for surgeries, advocating that they get themselves involved with levels of insurance, medical coverage, we will go a long way to making sure that they can access the health service that they need. Breaking down the silos around the surgical ecosystem. To dismantle these silos, we must include nurses in surgical policy discussions. We must fund interdisciplinary training programs. We must use nurses' frontline insights to redesign the workflows. We've talked so much already, we've heard so much about the NSOAP. Nigeria even did better with NSOAP by including the second N, which now makes it the National Surgical Obstetric Anesthesia and Nursing Plan. But like I said, the issue is always implementation. We designed a very beautifully integrated training, but it hasn't happened because there's no funds. And with time, we moved to another policy. We moved to adopting a new one, but we have adopted so many that we have not really implemented to the level of those policies being beneficial to the Nigerian citizens. So final messages. Nurses aren't just part of the surgical ecosystem. We are the glue holding it together. Let's break the walls together. Thank you. Lessons learned. Success comes in small changes, like nurse-led triage, by task shifting, so that the nurse doesn't really have to wait for the physician to carry out some basic actions that would really mean life or death for the patient. Barriers, resistance to change, funding gaps, and lack of data sharing. We've talked about, one system, having one goal, having one implementation plan, and having one reporting platform. Integration starts with trust, nurses advocating for patients across the departments, because we are really the heart of healthcare system. How can ACAN support? ACAN can support us by scaling up shared adapted model, low cost ICU training, like we have said. We have lots and lots of SOPs, training models, but we really need to step down the training from across the levels of care, particularly to the lower level, because they are closest to the community. Sustainable funding, advocate for bundled care, not siloed grants, so that things can be done integratively. Data-driven changes, support unified record keeping, like I have said, to track patients' journey. We need ACAN's platform to amplify Nigerians' voices, because integrated care saves life. Call to action, final quotes. Alone, we can only work in silos. Together, we build systems. Integrated services isn't about the skills or resources. It's about the policies we dare to change today. Let's rewrite the rules and making the nurses more inclusive in the plan from the outset. Thank you very much.
Thank you, Dame Okafor. I think I have about 15 quotes from you that I want to take after this. So we really appreciate it. Thank you for the inspiration as well. So our final speaker for the panelists today is Jed Williams. He's coming to us from the World Federation of Critical Care Nurses, as we continue to talk about nurses being the foundation and the blood of our, not just our surgical ecosystem, I would say our entire healthcare ecosystem.
Thanks, Camilla. Good morning, everyone. Acknowledging my president from the World Health Organization, Amelia. Thank you for coming along. It's an honor to be here to share with you the World Federation of Critical Care Nurses journey, and how we might be able to help and learn from this movement, the ACAN group. Oh, we lost our pictures. That's interesting. There's a beautiful picture there of our organisation leadership when they first formed in 2001. Basically, 70 nurses joined a side meeting of the World Federation of Intensive Care and Critical Care Medicine. It was their 8th Congress in Australia. 8 of us came prepared from our national societies that we could form an international organisation at this meeting. 8 countries had made that commitment. We had 4 sheets of paper, which was our constitution. We had no money, but we had a lot of passion. And we elected our inaugural executive team. This is going to be frustrating. It seems like not all the slides are going to come through as they're required, but that's all right. It's all up here. I've been part of this story, so I'll just make it up as I go. But what we did prior to forming our organisation, a group of us spent 2 years profiling 21 countries and their critical care services. And we published this paper that guided the way in which the World Federation should be formed and what our role should be. So the overwhelming response from the respondents from the 21 countries that were involved was that it needed to be a federation of organisations, not of individuals. It needed to be mainly policy driven, and everything that we provided needed to be free of charge. So we took all that on board. And since that study, every 4 years we do a similar study worldwide. Our most recent one was published in 2021. We profiled 100 countries in that survey, and we're just doing our 7th quadrennial study now. And we're hoping to profile maybe about 140 countries and their critical care services, activities and needs. How are we doing there? That's all right. We're good. As I said, I know this story pretty well. Some of the things we've put in place to help communication and collaboration is we do have an online journal, which is open access, and we particularly support people from low-income countries, emerging researchers, and people who come from non-English speaking backgrounds to try and give them a platform to publish their work and to share their ideas and experiences. We also have a website which has a lot of useful information. This slide was about every year we have an international conference somewhere in the world, and this year's conference was in Dubai. Next year's conference will be in Nepal, and we try and find different parts of the world to bring people together to share their ideas, to present on their new initiatives, and to form networks and friendships that they can continue to use ongoing. One of the great things that I think our organisation has done has been the empowerment of regional groups to get together to have their own federations. And in 2007, we helped form the Federación Latinoamericana de Enfermería en Cuidado Intensivo, and my Spanish friends will correct me where I got that wrong. But that is a great group. They're a Spanish-speaking group. Most of the countries in South America, at least, and some of the Central American countries are part of that organisation, and they're quite strong and independent now and running their own agenda, but they also belong to the World Federation of Critical Care Nurses. We've done a lot of work in Africa over the years, trying to help countries form critical care nursing organisations, start to form relationships with one another, eventually culminating in the launch of the African Federation of Critical Care Nurses in Uganda in 2017. We've probably had about 5 or 6 conferences in Africa since, supporting that group, and with members of the World Federation of Critical Care Nurses being actively involved. And I'm very proud to say the role it's given me is that I'm the patron of the African Federation of Critical Care Nurses, which basically means I've got to try and find the money. In 2017, I think it was, the SARC countries formed a Federation of Critical Care Nursing organisations as well, and we'll be having our World Federation Conference in Nepal next year. So it'll be a great opportunity to bring the leaders from those countries to see their progress to date and also to support them in their ambitions going forward. And of course, continue the discussion about the role of WHO, ACAN, and what their contribution and how they can align their activities with these broader global activities. We have a Southeast Asian Federation of Critical Care Nurses. They formally launched in 2018, but they started their journey in 2003. The leaders of that region who thought that they would like to form a federation in that region in 2003 were clearly ahead of their time. And so some of these things take time to get engagement, for people to know their role and their place, to find the resources to support people to get involved in these much bigger activities, and then to find really meaningful activities that they can work on together. Last year, our organisation wrote a memorandum of understanding at our conference, which was also in Dubai, and we had Dr. Amelia and Lee Wallace join us to have discussions about how the World Federation of Critical Care Nurses and our colleagues, the World Federation of Intensive Care and Critical Care, mostly medical, how we could work together collaboratively to try and support the ambitions of the World Health Organization. Our two boards, the World Federation of Intensive Care Medicine and Critical Care Nursing, also had joint meetings, which we hadn't had for a while. So that was really good to bring us all together post-COVID and to start to look at how we work together more collaboratively. And just last week, we had a meeting in Dubai and a conference. Our two world federations signed a memorandum of understanding to really provide clarity about the importance of our organisations, the doctors and the nurses working together, working collaboratively. Our boards met again and started to work through what were some of the priorities that we should be looking at together to advance critical care practice, and particular our role in supporting ACAN and the World Health Organization and coming to meetings like this. And last night, my two medical colleagues, Javier and Jorge, who are both in the audience today, we got together and we said, you know, after this meeting, we're going to have a cup of coffee and we're going to start working through that agenda and the things that we can do together collaboratively as doctors and nurses who lead the world of critical care practice. Other meaningful things we do, we really try to support collaborative research that is global in nature. And our most recent publication looked at the challenges of compliance of sepsis management protocols in low and low middle income countries. And we're able to profile feedback from 24 low and low middle income countries to help identify what are the barriers, but also what are the strengths? What are some of these low income countries doing to try and comply with known best practice? And what are the workarounds or the creative ways that they find to still deliver good care to patients with sepsis despite having limited resources? And I think this is the mindset we have to take to these questions. It's not about what we don't have and what we can't do, is what can we do with what we've got and with the knowledge and know-how that people bring to these discussions. So where to from here? Clearly, the memorandum of understanding with WHO and the ACAN and ECO agenda are uppermost in our minds at the moment. What can we do to facilitate the top-down guidance that comes from WHO and the bottom-up commentary that comes from our member associations is going to be really important. Continue to work with our partners. The World Federation of Intensive and Critical Care is a really important relationship. We're a founding organisation of the Global Sepsis Alliance. We're exploring what our relationship with G4 might be. So we're open to work with anyone. We're nurses, we're friendly, we like working with our colleagues. So that's who we are. Strengthening these regional federations, I think, is really important. I think that's the future of our organisation, empowering them to drive the agenda in their regions and respond to the needs of their associations. Supporting new national critical care nursing societies, particularly in low middle income countries. I'm really pleased to say that the national critical care nursing organisations in Cambodia, in Tanzania and Nigeria are all members of our organisation. So we've got pretty good reach across the world. Basic critical care programs in low middle income countries. That's a really important agenda item for ACAN. It's a really important agenda item for our two world federations, and we're looking to see how we scope what's going on to see where the gaps and needs are in that area of practice. Providing evidence-based position statements. We've got about 6 at the moment, and we're hoping to form more with our medical colleagues to provide guidance around practice throughout the world. And mentorship programs for emerging global leaders. The next generation of people who come behind me and my colleagues who form this organisation, making sure that they're empowered, knowledgeable, and know how to lead the organisation and the collaborations in the future is really important. And we're absolutely committed to the 76.2 resolution. We think that's a really great step forward to really try and drive not just critical care, but how critical care works with emergency, works with perioperative, and the whole health journey of our patients. Thank you.
I'm going to invite Terry Reynolds up here just for a moment.
Hardly needed at this point, given the call outs that you just heard. But I wanted to ask my colleague Amelia to stand up for a minute because she has really been my partner in crime to mix the metaphors even further. For those of you who don't know her, this is our chief nurse at Divicha, which is quite an extraordinary position from which to advocate. And this is really something we've all done together. She would be leading this event, in fact, had she not had a conflict at the Palais, which she has run away from. So not only is she here, but she's here instead of being at the Palais. So thank you, as always, Amelia.
Just wanted to give an opportunity. We have just a few minutes for questions and for our esteemed panelists. So I wanted to give everyone a quick opportunity if anyone has a question. Otherwise, I will take the speaker's prerogative and ask my first question. So maybe as you're thinking, I'll start off. So as to our colleagues here, how can ACAN support in-country activities and help with feasibility and sustainability?
Yeah, thank you very much. Like ACAN can really help us to rewrite the current system that we're writing, that we're using, whereby you have physician-centered care, so ACAN can help break the walls and bring other healthcare workers that are actually stakeholders, to the center, giving them the recognition, the training, and the voice that we all need, in caring for the patients. Thank you. So more of support, high-level advocacy, for us to move the direction of high-level countries, for the healthcare system to really work for the citizens, not the big titles, but really getting people that are hands-on and quite close to the community, getting them appreciated, getting them involved in policy making, not just the policy, but seeing through to the implementation. Like I said, our ENSOP document is superb, but we actually planned integrated training, pulling people from the baseline, the community, made up of the nurses working in the perioperative space, the early career doctors, because those are the people you get at that level, and every other person that works in the space. But then who pays for the training? Because the people that had been contracted to do the training, coming from the surgical, what's the name now? Consultants group, coming from the nurses group, they are not going to train for free. Even if they would train for free, there are certain logistics, getting the right people together and training them. So funding and policy change. Thank you.
Thank you very much for the very good question and the contributions. And to echo what you've said, I think training is really important as a way to ensure that our nurses and our younger colleagues who are actually with the patients know what to do. And I think with that, we need to ensure that this training is sustainable. And I think the models that we have been using a lot with people being trained in silos, people coming in to train them from elsewhere, needs to be improved in such a way that we train trainers within the areas where people are, so that they can sustainably continue training others. And for this to be feasible, making sure that these patients are receiving the care that they need within ACAN, I think we need to work together with the governments and ensure that funding that they have, we don't have, we cannot rely on funding coming from outside, but whatever funding we have as nations has to be taken into consideration that many patients need this care across the care provision framework, and it needs to be one of the baseline things that all initiatives that are happening, be it HIV, malaria, surgery, all these patients need this continuum of care. So whatever comes in, maybe a percentage of whatever they're putting in together has to go into this initiative so that all our patients benefit from the work that we're doing for it to be sustainable. Because right now, most of what we're having is these siloed fundings that are coming from outside and they're not sustainable. So once they die and the systems also disappear, we see good initiatives coming in, well funded, they're working so well, but once they leave, we cannot continue with that. So we need to find a mechanism to ensure that our governments listen to us, and being working together as a coalition with this, makes our voices more powerful to speak to the governments, to show them where the gaps are through evidence, so they can support this and improve the care for our patients.
Okay, I would like to add how to realize the program of ACAN and the break of the silo. The lesson learned from Cambodia, I think beside of the policy supporting or the government supporting, I think at the level of the policy maker, we have to integrate also the silo program, because at the level of the ministry we have different program, but some program is overlapping. For example, in mother child care, and so or now we have critical emergency critical and operative care. So I think we have to integrate how to integrate all the program, the guideline together, because at the level of the application at the district hospital or provincial hospital, we lack of the human resource, and we create the different programs. So the key person of each program have also it is the silo also, and the main success is beside the good program or policy, we have to encourage and integrate all the services, and especially we focus on the training, but how to retain the provider healthcare staff at the provincial hospital or district hospital. So in Cambodia, we are improve a lot about the policy, and we also create the incentive system to retain the staff at the level of rural area. And also we create the culture of the collaboration, communication as a big teamwork, not only in surgery, in obstetric different, but all had to integrate, and the healthcare worker or the specialist have to work together and help each other to provide the emergency care and operative care for the patient. This is my point of view.
We have time for just one question. How about it?
Thank you very much. And I noted, sorry, Neil Wetzig, President of the G4 Alliance, but I noted that the Chief Nursing Officer from Nigeria said that one of the barriers was a lack of data. And I just wondered if you could make any comment about the role of the WHO clinical registries in across the board emergency trauma and the operative care registry that I'm involved with, that in improving quality and being able to break down those silos.
Okay, thank you very much. And like you know, They say data is life. If you have the right data, you can now plan, for your intervention. Yes, Nigeria, we are good, in keying into WHO policies that, like I have said earlier. Right now, we are at the point of trying to get our trauma registers across the states, 37 of them. So it seems slow because we have to really cover all the institutions across the level of care in order to get the right numbers. And other registers too, we actually leveraged on the cancer registry in order to be able to navigate lessons learned from cancer is helping us to get the trauma registers ready. And we know that when you have the numbers, you can plan better with the little resources. So WHO policies help us a great deal. We only need to start a step forward in implementing. Thank you.
I'll just make a quick comment on that, a broader conversation, which is about where I think the WHO and ACAN can really help is where registries or where processes of collecting information or developing training and all these things, where it's happening well, facilitate ways in which it can be modified in such a way so it's accessible and usable by the lower income countries. My observation over the years is there's more than enough resources and capability in the world. It's just distributed really badly. And I think the WHO has a really important role in guiding us as to how we can distribute some of this knowledge and capability to other places, which won't cost us a lot of money. I think we just need, those of us from richer countries just need to be a little bit more humble and a little bit more generous in the way in which we apply these opportunities.
One last question, and then I want to make sure we have a few minutes just for wrap up.
Thank you. Mine's not really a question, but I just wanted to maximize this opportunity. Because they say closed mouths don't get fed. My name is Lola Miriam Ali, and I'm from Nigeria. We run potentially the largest public-private partnership intensive care unit in the country. This is a center that we took over that had been laying abandoned with cobwebs and the likes for 4 years. And we cater to low income and lower middle income patients. So you can imagine how tough it is to provide quality critical care in the face of very, very limited resources, very, very limited. But with really good work, good ethics and whatnot, we achieved a mortality rate of less than 5% last year, which is quite good. Over the past 4 years, we've been working to build the first pediatric intensive care unit in Kano that would cater to children with congenital heart disorders. This is the first of its kind, not just in Kano, a state with over 25 million people, but the entire northern Nigeria, a region with over 100 million people. And this center is just going to be 10 beds. This is to give people an idea of what my esteemed speaker was talking about, in terms of the gaps and whatnot in our country, and to a large extent, much of sub-Saharan Africa. So this is not a question, but just to throw it out there, because there are a lot of people here from different organizations. If there's anyone that would love to know more about what we do, that would love to support us, that would love to discuss ways that they can partner with us, please reach out to me. I'll still be here after the event. The whole purpose of this event for us is really to meet with those in the international community that might have the resources, or whatever the case might be, to help centers like ours. So thank you very much.
And that is exactly why we want to end early, to give you time to network with one another and to really be able to think about, I think, the culture of collaboration and communication. I think Dr. Lemmy mentioned that. I think that's so important. I'm gonna invite Terry up just to give a few last words. I guess, okay, I was furiously writing notes down, just as we were thinking about some of the recaps here. I think one of the things that we think about with ACAN that's gonna be most important in this network, and I hope you guys have an opportunity to do that over croissants and coffee, is to bring the voice of frontline workers to the forefront. Training must be sustainable, and we must be thinking about building capacity where people are, not just bringing that in and then leaving. Culture of communication and collaboration, I think, is so important. Data is life, and data drives improvement. And we have to keep that at the forefront as we think about how we're going to use ACAN, both to support the initiative, but also to sustain the initiative as well. Workforce development is important, and simple actions can make a huge difference on patient outcomes. I think Dr. Khalid, you had mentioned that, especially if you think about the BEC and the BCC courses, the basic emergency care course and the basic critical care course. Very simple actions, very simple training, but could have a huge impact on patient outcomes. Breaking of the silos, I think, is very important, as we've heard many, many times. Integrating the government, not into supporting the healthcare system, but also supporting the fact that these initiatives have to be continued, and making this a priority within the government infrastructure is going to be important. And that is going to take high-level advocacy as well. And then just finally, thinking about the lifeblood of this work is really the frontline workers, many of whom are here in the audience today. So I think, we've had an amazing opportunity to hear from our great speakers. I hope you take the opportunity to ask them many more questions and to work within the network as well. We also invite you all to join ACAN if your organization is not already a part of it, or if you're interested in learning more. And then, of course, we have opportunities that we're looking at to help continue to sustain this through funding, opportunities to work together as well. And then I'm gonna have
We'll put up the
yeah,
QR, we'll put up the QR code now that will take you straight to the.
So we have a few QR codes that we wanted to share with you all. So this is how you can join ACAN as well, and to learn a little bit more about it. And then we also wanted to introduce you to some of the activities that are also going to be ACAN related that are going on here at as side events as well. So tomorrow from noon to 2 p.m. at the Geneva Press Club, we have the Data to Action activity that's going to be happening. We also then have the Strengthening Acute Care Systems to Save More Lives. That's going to be at the ICRC Museum tomorrow night from 6 to 7:30 p.m. And then on Wednesday, we have the 70th World Health Assembly site event, specifically looking at another, again, ACAN activity as well. So please join. These are all open for people to register right now. We hope that we can continue these conversations, not just today, coffee, but also throughout the week and then throughout the year. Thank you again so much for coming. We appreciate it.